Thank you for the introduction. Good evening, everyone. And I think let's get started with today's discussion. And then the topic is going to be the telemedicine practice guidelines as it was released in India. And not just about what it covers and the scope of it and what it excludes, but then like I would like to sort of discuss how it has impacted the entire virtual consultation ecosystem in India, whether it is research or it is industry or in terms of practice, how it has impacted various areas. Just to give a quick overview of what India is, I'm sure that most of you will be knowing it's the second most populous country in the world. And in terms of landmass, it is the seventh largest, and it has 28 states and 8 union territories. That makes it quite a big and diverse country with 22 major languages. Of course, we are about to become the leader in terms of the population. And in India, health is actually a state subject. And in terms of doctor-patient ratio, it is less than the recommended ratio from WHO. And India, it's a country of paradox. I would say that we have some of the best facilities in terms of medical care in the country, where we are one of the top destinations for medical tourism in the region. And then at the same time, there is a unequal distribution of critical resources, like especially, for example, critical care specialist or mental health specialist. Like, we have this kind of an uneven distribution. So that makes telemedicine all the more important. And in terms of population, this the figure that I have put on the left-hand side shows how the population of 12 other countries can actually fit into India. So let me give a quick overview of what all developments that has happened in terms of regulatory environment for telemedicine in India since the late 90s and early 2000. We were having few hundreds of installations all over India, and then we had certain efforts for standardization, and then we also had efforts to actually take it to for a legal regulation, but then that did not successfully transform into something that's legal at that time. And then it took all the way up to the COVID crisis in March, when Government of India released the telemedicine practice guidelines. That actually, I would say that it's a renaissance for telemedicine in India. And that also triggered a variety of events and developments in the country for the ecosystem. If you can see the timeline, on March 21st, government releases the telemedicine practice guidelines. And then by April 7th and April 10th, already two other alternative systems of medicine, because whatever the government released is meant for allopathy, but other alternative systems of medicine quickly picked it up, and they released their own telemedicine practice guidelines for their systems of medicine. And then on May 12th, a very important development happened, wherein actually Government of India, through the Board of Governors of the Medical Council of India, amended a key regulation that dated back to 2002. And then that was also notified into a regulation in the Gazette of India on May 14th. So that is the D-Day for telemedicine in India, I would say. And on June 11th, yet another very important development happened, because for telemedicine to sustain in the country, you will all agree that support or coverage from insurance is very critical. That was not the situation till so far, but then now it is. And then now, as long as the policy has cover for a consultation with a medical practitioner, telemedicine is actually allowed. And then the Insurance Regulatory Development Authority of India, IRDAI, has already sent a circular that says that you have to actually allow telemedicine to be part of the claim settlement rather than having it, approach the authority or for any modifications. And recently, from October 1st, it is also covered in all health insurance policies. And then wherever there is a physical visit is covered, telemedicine is actually covered. So this I would say that though there have been many other developments, very many developments, but then I would say that with respect to regulatory environment, these are the major developments. And then later on, I would also mention about the uh, privacy and data protection bill, which is still pending in the parliament. If and when it is approved and becomes an act, that is going to shape the telemedicine ecosystem in the country further. So quick round of definitions. Of course, as far as telemedicine practice guidelines are concerned, they adopt or use the telemedicine definitions that is from WHO, which all of you are already aware, as well as telehealth. From the NEGM Catalyst definition is what the government has taken for as far as the practice guidelines are concerned. But I would like to you to know what is this registered medical practitioner. They are nothing but the doctors. But then the Indian Medical Council Act 1956 defines them as someone who is registered either in the state register or in the central register, which we call as the Indian Medical Register. So this term will be actually becoming this term RMP I'll be using that quite regularly. So I would like to know that they are nothing but doctors. So what is actually the scope of this practice guidelines? Who can actually practice? Those who are enrolled into the state medical register or the central medical register are the ones who can practice telemedicine in the country. And the practice guidelines basically covers all the norms and standards. I won't say, when I say all, which is right now very much applicable in the current situation, because they sort of didn't make it very heavy. They didn't make it, they didn't try to make it all comprehensive, because right now they want to telemedicine to serve the purpose in terms of when people are having this difficulty in getting to the hospitals during lockdown. And so they sort of, but it is a living document. They are absolutely open. The government is absolutely said that it will be amended from time to time, and then it is going to be a living document. And then the best part is it allows all sorts of medium for practicing telemedicine. You can call it, whether it is text or WhatsApp or a regular video conferencing system, voice data, like whatever means of actually practicing telemedicine. All those modes of communication is allowed. That is another big development. And then exclusions. They are not actually talking about any specifications for hardware, software, and infrastructure and maintenance, because that will get into further complications. Right now, they want the patients to benefit from this service at the time of the need. And they don't talk right now about standards and interoperability. Of course, like there are a few grudges for that, but then like it is understandable. But the government is quite willing to bring it in very soon. And any forms to conduct surgical or invasive procedures are not permitted in telemedicine practice guidelines. And research, evaluation, and continuing education of health workers, that is another thing that is not so far covered. But also, India is actually known for giving telemedicine services for countries abroad. In Nighthawk teleradiology is very well known in India. This practice guidelines right now keeps the jurisdiction for practice within the country. So these are the 7 elements I would like you to actually focus on, because regarding the details of the guidelines, we can always read it. But then what the guidelines talk about these 7 elements. These are the core elements that we need to be familiar with. The context. So is telemedicine appropriate for a particular context? And then is it sufficient for a given situation? So it talks about it. And then positive identification of doctor and the patient. So what it says is the consultation should never be anonymous. So at the beginning of the consultation, the patient should know the doctor, and they have to sort of introduce each other. They should know, and then there should be a formal identification of each of them. So that is the beginning of the consent. Text and many forms are allowed. And there are 2 forms of consent. That is implied consent, when the patient actually initiates the consultation. And then the second one, when initiated by a health worker or a doctor. So it involves, like, if it is an implied consent, there is nothing that the doctor needs to sort of specifically obtain a consent when the patient initiates, that means. But if the patient does not initiate, there is a need for actually taking the consent of the patient. So there are two types of consultation. One is the first consultation and the follow-up consultation. The practice guideline says that after a physical visit has happened, 6 months, you can have follow-up consultation. But beyond that, you need to have an in-person consultation. And then, of course, like patient evaluation is left to the professional discretion of the doctor and the patient information that is available. And then they also say that both the patient as well as the doctor can actually terminate a consultation if they are not satisfied with that, giving notice to each other. So if, for example, a doctor feels that the information that is being presented or being available to him or her is not sufficient to arrive at a proper clinical judgment, he or she can actually refuse to give and then ask them to come over for a physical visit or refer. And then wherever patient education is required, they can actually give the advice related to the specific clinical condition. But with respect to prescriptions, again, government has got and then given some restrictions because dispensing of medicine, and there are specific laws governing that. So they have specified 3 types cannot be prescribed over teleconsultation. So let's look at pre and post release scenarios. I mean that pre-release of telemedicine practice guidelines and the post-release of telemedicine practice guidelines. So this, what I did is, like, I spoke to a few of my friends, both in terms of lawyers as well as clinicians. I just asked them what telemedicine practice guidelines means to you, because I thought that this could be a value addition to most of you to see what others in the country who are actually in the connected to the practice are actually practicing telemedicine, if they can share what it means to them. You know, she's a lawyer, and then she is also a part of Telemedicine Society of India, and she shares her views pre and post. So what she says is, like, before the notification of this telemedicine practice guidelines, there was ambiguity in terms of the laws that are applicable, scope and practice, and scope of interaction with patients, and what prescriptions can be given online or not, and consultancy fees. Because many people sort of assume whether if you provide a physical, whether if you provide an online consultation without a physical examination, should the doctor actually charge for it? The practice guidelines say that you can charge the patient and then give a receipt. So it also allows. And then what has changed post the introduction is the legal framework, and the guidelines have given a proper structure right now. And it is actually leading to much more development in terms of the scope and the adoption of telemedicine in the country. And it has sort of brought, I would say, that parity between online services and then those that for in-person visits. And then it was also recognized to various stakeholders that is involved in the ecosystem of telemedicine. And it is also making affordable care available to the patient. This is the view of a lawyer. And let me quickly summarize. So what telemedicine practice guidelines are meant for and what it is. So it is actually for government released it to make sure that the registered medical practitioners use it to enhance the health services and access to all in the country. But then it's not just limited to the pandemic. It is expected that it will sort of continue and develop further beyond this era of pandemics. And then who can practice are those registered medical practitioners who are registered under the Indian Medical Council Act, or who are considered as registered medical practitioners under this act. They are the ones who can practice. And then telemedicine practice guidelines are not applicable for conducting surgical procedures remotely. And in terms of the drug list, it has already been modified once. And the Board of Governors in the supersession of Medical Council of India had said that from time to time, as per the need, they will modify the list if it is required. And then in terms of any required clarification in terms of the guidelines also, they will be able to give. And then this document can be amended also from time to time in public interest. And then another important aspect is many countries have these licensing issues that a particular physician has to be registered in a particular state. But as I mentioned, like in India with many states and union territories, here a registered medical practitioner or a doctor is allowed to practice teleconsultation to patients from any particular state, province, or union territory in India, from any part of India. And in terms of uh, uh, professional and ethical norms and standards, the practice guideline says it is no different from an in-person consultation. The same set of norms and ethics that a doctor needs to observe during an in-person visit, the same has to be followed even for an online consultation or telemedicine. And let me give a quick overview of some of the national projects that has happened. Here, there have been so many deployments all over the country, but I'm taking a very limited sample, which can be termed as national in terms of scope and scale. So there are two types of telemedicine initiatives that has been started by the central government. One is this National Teleconsultation Center. It is a 24/7 hub based out of All India Institute of Medical Sciences in Delhi, which is a national referral hospital. And here it has been equipped with a multimedia center, which can actually connect with doctors from all over the country. They can take queries, and the specialists in this hospital belonging to various clinical departments can actually guide those doctors on national guidelines and protocols. And it is a doctor to doctor interaction here. And then this particular center is also connected to the National Medical College Network, which is actually part of National Telemedicine Network, which networks about 50 medical colleges. And then this network was extensively used during the current crisis, for example, training on ventilators and things like that. So this particular network was very useful for capacity building. The second effort is eSanjeevani OPD. It's known as National Teleconsultation Service. It's a virtual OPD. Uh, it's like during the lockdown period, people need not actually step out of the home to go and meet a doctor. When they have the difficulty, they can actually reach out to the doctor and have a secure video call. So it is a free national OPD service, which is available for all patients. And then the doctors are actually chosen and empaneled by each of the states who are participating in this particular scheme. And this is available as a web application as well as an Android mobile application. And it was designed and deployed by the Health Informatics Group at Center for Development of Advanced Computing, which is an R&D unit from the Ministry of Electronics and Information Technology. So what it does is ensure that standards-based teleconsultation is happening between the patients and the doctor, and it is also safe and secure. And requirements are like anyone with a stable internet connection, with a laptop or a PC or even a tablet or a mobile phone with a larger screen and a Chrome browser can actually take this service. It has been functional since 14th of April and is being currently used as of today. It is used in 23 states and one union territory. And in fact, if I remember, recollect right, just a week ago, they had crossed about 500,000 consultations already. So how it works? Like basically the patient or someone like who needs a consultation, they verify their mobile number using UOTP, fill up the registration form, and they can upload any of the records, scan and upload, and receive a patient ID and token through SMS. Once that is available, they can actually log in with this patient ID, and then they will be placed in a waiting room, and then a doctor from the same state as the patient will be assigned to them, and then a call button will get activated when the doctor is available to take the call. So a video call can be initiated, and then after the consultation, they can actually download a e-prescription for taking to the pharmacy for their medication. So this is actually a end-to-end system, and this has actually been very successfully working. It's a free service, but it has been suspended. But I thought I will nevertheless share, because we are talking about regulations and the impact. So this is a public-private partnership that was started right at the beginning of the pandemic. So it's not only provides free online consultations, they also added some ancillary services like you can order online medicines online, as well as order lab tests, because people may come with the kit and conduct the test. So that kind of a services, people, their famous logo is like, you don't need to step out, we will step in at your doorstep, we will provide the service. And it was a very ambitious initiative. And then but then it was discontinued because there are some issues with respect to objections from the retail chemist, because they feel that online pharmacies are promoted or marketed, and then they feel that they should also be listed in the portal. So that with that, like, the government has actually withdrawn the service. But then they, because due to the uncertainty in the business model being used by online pharmacies, and then because there is a rule which is very archaic right now, the government has been working on that, and then hopefully very soon the regulations for e-pharmacies in the country will be set. The third initiative is again a voluntary initiative. It's again is a helpline. It's a triage helpline. Very interesting. It is entirely run by volunteers. So it's a non-profit initiative, basically aimed to augment the government resources, because when the government is bogged down with the COVID crisis, some of the startups, because India actually some of in Bangalore, it's a IT hub of India, and then there are many successful startups which wanted to contribute their resources to the use of the country. So what they did is, like, some of the technology startups and volunteer doctors and citizen response teams, again the whole set is a set of volunteers came forward and started providing this service, and they are using cloud telephony, and so that it can actually scale. There are no limitations, like they can take 100,000 concurrent calls. So this is the scale that they have planned. And then right now there are about 7,000 plus doctors in panel, and it is being used in 16 states. And per day, as I understand, like about 30,000 calls are handled for self-diagnosis. What it happens is, like, all calls are not directly actually routed to the doctors. There is a system that filters COVID and non-COVID, and if it is non-COVID, they are counseled accordingly. If a patient actually satisfies all the necessary conditions for it to be known as or suspected to be COVID, then they are routed to the doctors, and doctors provide the consultation. And if someone is sort of found positive, and they are also guided what should be done next. So let me also share some of the initiatives by professional societies and associations in India, having talked about the government institutions. And the Indian Psychiatric Society, in fact, they were the ones who first came forward and then issued a position statement as early as 30th of March, because they felt a necessity because of the crisis and then increase in the number of mental health needs, and then the kind of skewed distribution of psychiatrists in the country. So they advocated their members to actually move from clinic-centric to online consultations, and they also asked them to provide long duration and follow-ups to patients, as well as support health workers who are already involved in COVID care. So they actually lobbied with the government for relaxation and norms for refills for psychotropic medications, which are a bit tricky. So they actually lobbied, and then if I remember right, there are about 650 psychiatrists who had volunteered a few months ago actually for the service. And this is also again a free service. And the best part is the entire list state-wise is available for public in terms of like which day, which doctor is available for consultation and what is their contact and the language that they can speak. So this is a very helpful service. This is a particular capacity building program that was started by Telemedicine Society of India. It's known as Train to Practice because when the government released this course and then expected people to practice, not everyone is familiar with the practice guidelines. So Telemedicine Society of India, being a professional society involved with the mandate in this field, they took up this course, and within 10 days of the release of practice guidelines, actually, I was also part of the team. We put together a simple curriculum and started offering this course online. And it was a free course, and then they were also providing for a charge, but then predominantly it was a free course. And any doctor who is registered and practicing in India can enroll. And this is an online course and conducted through a webinar. It consists of 4 modules of 20 to 32 minutes each, followed by a Q&A. And we felt that though initially we were conducting even during the weekdays, we found that people are more participative or more participation is there in the weekends. So it was gradually shifted to the weekends. And then uh, the flow goes like this. So there is a registration of the doctor who wants to take this course. And there is a pre-course quiz. And there is this course which talks about introduction to telemedicine, introduction to teletriage, legal aspects, because this is one of the most important things which a doctor should know. What is expected and do's and don'ts as mentioned or expected in the telemedicine practice guidelines. And also we also talk about how to set up their own practice because they come from variety of disciplines. And then we follow with a question and answer session and a post-course quiz, and they can take a certificate of completion provided they pass the online assessment with a score above 80%. And this is another effort from Digital Health India Association. And this is an alliance, of course, led by the Digital Health India Association, along with a few other professional societies, like including HIMSS, which you all know about, and then few other organizations. Their primary aim was to actually assist the healthcare providers, the hospitals, as well as the doctors to in terms of procuring the right choice of telemedicine solutions, because there are so many solutions in the market. There are so many startups that mushroomed overnight. But then the effort was to make sure there is an informed choice is available for the providers to select and pick which meets the requirements as well as the expectations that are mentioned in the National Digital Health Blueprint and the Telemedicine Practice Guidelines. But though it was the primary objective, the Alliance also thought that it should help the industry because many of the solution providers are startups and they need support from a professional society in terms of adhering to the compliance requirements and standards. So it was actually an added benefit, which it is giving back to those solution providers. So far, as of last week, there were 150 telemedicine solution providers that responded, and then the survey is closed for now till November. And then 30 solutions have been curated for further evaluation by a panel, and the registry will be published in a week from now. Last week of October, they were supposed to come online. The evaluated list will be available online. So this is the methodology which I was mentioning about. There's a 3-stage, and then starting with self-registration, there is a secondary research was done on in terms of the compliance and shortlisting, and there is a pre-evaluation exercise followed by a evaluation, and then ultimately resulting in addition to the telemedicine registry, which the Alliance is establishing in the country. So what I did is, like, I also spoke to some of my clinician friends just to know how the telemedicine practice guidelines have impacted the practice and what it means for them. So I spoke to a psychiatrist, I spoke to a pulmonary and specialist and intensivist, and an urologist. So the pulmonologist said evaluating respiratory distress is now less stressful. And then after the release of the guidelines, it was prior to that, it was unimaginable to see a patient online who has shortness of breath. He says now we can effectively triage such cases. And then also, like, he says that like it also helps him as an intensivist to decide if remotely if the patient has to be retained in the ward, or he can avoid ICU or to be shifted to an ICU. And it has been a very, he also says that it's a very great moral support. These guidelines have been a great moral support. And then the best part is like, since the practice guidelines allows all modes of communication, so he says that 2G, 3G, 4G, 5G, all okay. And he's a critical care specialist, as the name is mentioned. I have mentioned the name. And next is a urologist and also a transplant surgeon. And he says that after the release of the telemedicine practice guidelines, he has been able to comfortably do 150 teleconsultations. And he says that 80%, that is the majority of his cases, were all follow-up cases. And then only 20% were new. And what he says as a most satisfying experience in practice of telemedicine is about long-term practice, long-term follow-up of patients without having to visit his clinic. And it will probably require only a minor alteration in terms of the medicine, or do some test and report that test result for further management. And he says that telemedicine has provided a template within which he can practice safe and ethical telemedicine, and also dispense medications online. And he expects a robust system to be available which has documentation, ensures safe backup, and fully secure. The third is a psychiatrist, and he is from one of the smallest state in India, which is located in the northeastern part of the country. And it has a very difficult terrain. And then it has sort of, because of the terrain, there are sometimes disruptions in terms of connectivity. And then, and he says that the patients were able to reach out to him earlier also, even prior to this release of telemedicine practice guidelines, but then they were not very clear regarding what such procedures could be actually followed, neither the patient nor the psychiatrist or the caregiver. Now, with the introduction of tele-psychiatric guidelines, and those confusions have been cleared, and both are comfortable. And he also points out one of the things which typically most of the tele-psychiatrists also mention. Because of online consultations, a lot of stigma associated with in-person visits to a psychiatrist is sort of mitigated. And he says that his medical college is planning to introduce general telemedicine consultations too, taking a cue from the psychiatry service from his department. So this is a recent development, National Digital Health Mission, which our Prime Minister had officially launched during the Independence Day on 15th of August. And this mentions telemedicine as one of the key building blocks. If you recall, I mentioned about a service which was suspended because of uncertainties related to the business models in e-pharmacy. Here, telemedicine as well as e-pharmacy are still undergoing a lot of regulatory changes. As I mentioned, the Privacy and Data Protection Bill, and which, when it becomes an act, both telemedicine is going to shape further, and then and also government is working on the regulations for e-pharmacy too. So both are essentially very much part of the National Digital Health Blueprint. And recently, as recent of last week, the National Health Authority, which is the lead right now for National Digital Health Mission in the country, has given an invitation to agencies for POC, for telemedicine building block, as part of this National Digital Health Mission. So that is the latest development which I would like to share. The road ahead, of course, like COVID crisis I think it's the same in every country. It has impacted our health systems, and especially the hospitals, because of the lockdowns and people unable to actually turn up at the hospitals. There have been lower outpatient turnouts and occupancy of inpatients, and it has also hit their revenues. So hospitals are actually actively looking at telemedicine right now to be part of their business model itself. And then repeated use of telemedicine, it's said like, practice makes leads to perfection. So earlier what was used here and now since it has been used now for regularly over weeks and months, it is gaining larger acceptance and giving confidence to both doctors and patients. And basically the whole perception of telemedicine is changing from what was just an optional, compensatory or interim is actually moving into mainstreaming right now. And it is also addressing the demand supply gaps, which I mentioned and gave an example of psychiatrist distribution in the country. Same applies to the critical care specialists too right now. And the laws applicable to telemedicine are those which are governing information technology, transactions, as well as the clinical practice. Both the laws which are applicable for practice of medicine, as well as transactions governing information technology transactions will apply for telemedicine too. And about this bill I had already mentioned. And what is expected is we need a periodic review because a lot of exclusions are there. Those need to be covered, and then it has to be amended and then made in line with other regulatory mechanisms which are yet to take place. That will actually shape the ecosystem further into a sustainable telemedicine services. And I have also listed a set of key references. There are much more, but then these are, I would suggest some of the essential things that which if someone wants to actually look up, you can actually go through this. It will be very helpful. Thank you. I think let's move on to the question and answer session now. Thank you for your patient listening.
Thank you, Sir Jai. Next, let's hear opinion from our reactors.
Thank you, Jay. I'm Sambath from Cambodia. So today I'm here as a reactor. So I like to say some for the Cambodia experience. So far, we don't have the national telemedicine or managed by the Ministry of Health. We have some for the standalone system or by practitioner, but mostly by the doctor to doctor. We don't have the patient to the doctor, so that we are still not much implement the telemedicine so in Cambodia. So we hope in the future we will more and work on this. And I have a few questions to Jay. So how when the patient get the consultation with the doctor, how the patient will get the prescription from the doctor? And the second, does telemedicine any include in social media, like a text or messenger or something like that? So thank you.
Yes. Telemedicine practice guidelines actually also specifies a particular format for prescriptions, so that the prescription basically has the name, age, gender, and the clinical observations, the name of the doctor, the registration, where they are registered, the registration number, and also their signature. It is a must. So this specified format is already available in the practice guidelines, which you can actually refer. In case if it is not clear, I can also send you the format which we have developed for our practice, which I can share that with you. It's a Word format. Basically, what is suggested is it has to be made clear this prescription is issued as part of a teleconsultation, and then the identity of the doctor, who he or she is, and the registration with the medical council is made clear by mentioning of the number, name, also the signature. The prescription, once it is made, it can be sent by any means. You should not type and send it as a SMS because you can't follow this format, but you can put it in a Word document or any other document or even a paper. Every doctor will have his or her own preferred stationery prescription pad, it is usually known as. They can actually write it down, take a picture, if not scan, and send it to the patient by email, or they can send it on social media, like for example, WhatsApp. It can be done. As long as they adhere to the specifications that is mentioned, it is legal. And that even an online copy of that, if shown to the pharmacy, it is valid. I hope I answered your question. If it's not, please let me know.
Okay, thank you.
Yes, there's a question. You also mentioned that they also see first-time patients.
Yes.
because many countries will always say for follow-up patients, you know. So you allow that. That means there is no that the relationship has not been established yet between that first patient and the doctor. So it is allowed in India, or there are certain cases that is not allowed for first-time patients.
Exactly. You need to have a prior consultation within 6 months. Within 6 months is because if it is beyond 6 months, what is suggested is you should actually ask the patient to come over for a physical consultation. They need to have basically the patient and the doctor needs to know each other. So that means they should have had a prior relationship. They should have had a consultation. But in case, if say even within the 6 months, if the patient is not consulting for the same cause, then again it is suggested that they actually have in-person consultation. But telemedicine practice guidelines also gives a lot of leverage to the doctors as well as the patient. For example, some people will say it's an emergency, like, we don't have any other choice. So they give this kind of flexibility to the doctor. They can actually provide consultations in situation where the patient has no other option, but they should be clear. They should be satisfied with the information or what they have to make a clinical judgment. If it is not, they should inform the patient and ask them to meet a doctor in person. I can see one question from okay, it's about like someone is asking me to share the guidelines. The link to the guidelines is already available in the presentation, but if somebody sends me a mail, I can also share it. And Dr. Bunchai has asked about how a patient can verify. A very interesting question, Dr. Bunchai. What happens is the doctor can actually show his identity, his registration number during a video call. So that can be verified if required. And most of the times what happens is like, I think majority of the cases in most of the countries, we typically tend to consult a doctor whom we already know. So the doctor and patient relationship is already established. But in case if it is not, or somebody doesn't remember, they can actually show their ID during a video call, or they can send the particulars to establish the credentials. That's how it is done.
Sorry to interrupt, Sir Jai. I think our friends from the CLMV countries have something to share as well on your presentation.
Yes, I'm from the Myanmar, and I would like to share a little bit about the telemedicine guideline practice in Myanmar. Myanmar is a newly demographic country and reached a critical junction to the telemedicine development with that ongoing political, social, and economic transition. And there is a real opportunity to the country to build up with the full potential of the telemedicine practice as well as the telehealth. So as of the telemedicine experience, Myanmar has started on 2006 with the MOU signed agreement on the India and Myanmar. The India provide a one-time grant as a 1.6 million US dollar to Myanmar to promote the development of IT through the establishment of the IMECTI, Indian Myanmar Center for the Enhancement of IT Skill, collaborated with the Ministry of Education, University of Computer Science, and the first step is about the telemedicine established on October 2008. Now it's the IMCITs provide the training in IT programs like the Java mobile computing and collaborating with the Ministry of Communication and IT. But Ministry of Health and Sport established a National eHealth Steering Committee and deployed the telemedicine practices with the digital health strategy. Initial implementation of the electronic data management in selected health facility at 2 sub-center level by 2015, in line with the National Health Plan. As Myanmar people is highly needed to implement telemedicine practice now at deals of the COVID-19 era, and also the 80% of Burmese citizens own the mobile phone as well as the smartphones. And also the telemedicine practice is the most widely popular in Myanmar from the private sectors and also GPs, and then they use their social media, video call, and communicate with their patients. The laboratory and investigate. My question is about the Myanmar is the public-private mixed healthcare system and the need-based primary healthcare. That's the currently telemedicine practice established from the private sector. In COVID-19 situation is the telemedicine and online consultation project started from the private sector, but the laboratory and investigation results are difficult to deal with it, and how to implement telemedicine practice, communicate with public and private sector as well as. And also clearly seen that the telemedicine is the essential rule to develop the guideline with the core 7 elements that Mr. Ganesh mentioned in his presentation with the 7 core elements. But at the MOH still lack of the telehealth initiated and telemedicine practice guideline, but the experience was started from the private health sector. Thanks.
Thank you, Aung.
Thank you, Dr. Yadanar. And next, let's hear from other opinion from our reactors. Any comments, Dr. Thepphouthone and Dr. Pham?
I am the Thepphouthone Sorsavan from Ministry of Health, PDR. First of all, I would like to thank you very much, Ganesh, for your interesting presentation, and also congratulations for your excellent products. The first, I would like to react for your telemedicine. I think that the Indian government is the awareness on this problem, and related to the consequence of this application. The guideline is the intelligibility. Like the organize of the guideline is the generally well include the other stakeholder, like insurance company and also the private sector. And I think this application will address the potential effects on the care situation in your country. I would like to share the information from Lao PDR. Right now, we use the DSIS tools in 2013, and the FOS, the minister endorsed this website to integrate with the health management information system platform since 2017. And we have some diseases like TB, HIV, and malaria were collected as the tracker system to follow up the treatment adherence and the outcome. I would like to give you the example for the we have some problem with the number of the HIV lost follow-up and not access to care is the increasing. For to solve this problem, we plan to use the message warning directly to the patient to inform them to get the medicine urgently. And in addition, the next 5 years, we plan to achieve the universal health coverage, particularly to improve the primary health care. But the major challenge is the healthcare access in the remote area. So that's, I think, particularly note that the duration in your country, in India, is applicable to Lao context as well. We don't have the much in terms of the telemedicine like Myanmar, but it is really I know that's the how you manage to develop the guideline in this really short time that you saw in the slide 4 is only from March to June is there approved and to use it really short time. I would like to exchange your experience how is going well like this. And
I would say, sorry.
Yeah. Oh, okay. You can answer.
No, sorry for interruption. Yeah, please go ahead. Yeah, please go ahead. I thought it's a question. Sorry.
Okay. I will certainly be interested to learn from your experience on the how the telemedicine service how you motivate the doctor or practitioner to provide the telemedicine service to the public. Do you have some incentive for the staff or not? Is it? And also, my question is, it allows we to have the national health insurance scheme managed by the National Health Insurance Bureau for the reimbursement for telemedicine claims will certainly require a lot of the convincing and would require the plenty of time to discuss a little on how India managed to negotiate with the health insurance providers. And we also know that this is really practiced core approach that is the build and existing network such as the phone or managing system. Less than having the invest in the expensive IT infrastructure. In Lao PDR2, there are the high use of the smartphone and the messaging the applications such as the WhatsApp in the urban center. I would like to ask you how has the India plan to extend the telemedicine, particularly to the hard to reach the population in the remote area. Yeah, it's finished for my comment.
Thank you.
And question.
Yeah, thank you. Thank you. First question, I would say that it was not very fast. Means developing this guideline, or probably after the release, the further developments were happening very quickly. But then prior to that, like as I said, like we were into telemedicine and we wanted to have some regulations for that way back in 2003 and 2006 onwards. But then it happened only now because the crisis actually pushed us to do that. So I wouldn't say that it happened so fast. It has been growing. It has been in the minds and thoughts of people, and people have been sort of like working on it and contributing, and then various professional societies or industry has actually been lobbying for that. But then it happened because currently there is a bigger need, and then the government came forward with the guidelines. But then the work has probably started, or at least the thought process has already been started, or the need has been felt long ago. And then with respect to how the rural population can be reached, yes, like that's the thing that happens in many of our countries too. But then India has got a very high level of penetration of mobile phones, and then a whole lot of people even have smartphones in the country right now. And then right now, even a lot of mobiles are being used for online education by the kids. Most of them are using their phones for attending online classes. So that way, we are relatively now better connected in the last few years, I would say. And the connectivity is also improved. And a whole lot of consultations actually does not happen in a high-end video conferencing. And then it depends on the need. Like, for example, my own institution has a high-end video conferencing it uses. for certain surgical procedures or mentoring, or when you have some grand rounds and things like that. At the same time, we also have other forms where you don't need that kind of an high-end video conferencing system. So naturally, the requirements in terms of computing machinery or the connectivity can even be lower. A whole lot of doctors are actually practicing even on social media. As long as you adhere to the telemedicine practice guidelines, it is allowed. So in that way, like, say for example, in your country, if somebody is already using a messenger or a WhatsApp or whatever means, if required, that can be done. But there is a caveat. The documentation becomes an issue, because I'm sure that most of the countries will have their own requirements of maintenance of medical records, which will be a legal requirement. Maybe some of the records like inpatient and outpatient records have to be stored for certain number of years, and certain data has to be there. So those becomes difficult if we don't use a proper health information system to support, or an EMR to support the practice. So that is the only difficulty. But in terms of emergency, when you don't have anything else, there are workarounds available. Like if required, like I think off the line, like I can also share some thoughts on that, which can be done without major investment. I hope I answered all of your query. If not, please repeat. I would be glad to answer.
How about the incentive for the health practitioner?
Yes. That's a very good question, because why should someone offer it free? And then there are people who are already offering, they willingly give. And then of course, like when somebody is, that's a bread and butter, right? Like that's a practice. If every consultation is going to be free, then what will they do? So it is the telemedicine practice guidelines actually allows them to charge. And then when the patients who have been going and they cannot actually meet in person, they are okay to actually do this consultation online, and they have been paying. In fact, many of the, for example, certain associations, like for example, Indian Association for Pediatrics, or any of these medical associations, they came up with their own guidelines and are helping those their members to actually practice telemedicine for payment. So they said like how online payments can be accepted and then verified and things like that. So one of the motivation is of course like a personal motivation to do it as a service, but that's not the only motivation. The government also can subsidize. Other forms of motivation is like, for example, if someone does telemedicine and then that experience is sort of documented, they would like to sort of, many of the academicians too, right? They do certain number of consultations, they work on a research on that or publish it. That kind of a motivation can be there. But I think the main motivation can be in the form of either professional satisfaction, also a financial compensation. Unless otherwise insurance or someone compensates, it may not be sufficient to sustain in the longer run.
Thank you, Sajai, and
okay, thank you.
Dr. Thepphouthone. Next, let's hear from Dr. Pham from Vietnam.
Maybe Dr. Pham that is having some difficulties with his audio. Dr. Pham, maybe we can entertain one more question.
Okay. I will choose one question from our participants. Question is, will an anonymous telehealth consultations help in improved participation for behavioral or psychiatric disorder management if prescribing is not planned?
Anonymous consultations are not allowed because telemedicine practice guidelines clearly says that there has to be, the patient has to know the doctor and the doctor has to sort of know the patient. There are anonymous consultations are not allowed. Does that answer the question?
Yeah, thank you, Sir.
Now I can share some experience from Vietnam. The first of all, I think the presentation from India is very valuable knowledge, and I think the strategy of the medicine system from India may be similar to the Vietnam. The telemedicine in Vietnam is developed very soon from when Vietnam have a program about telemedicine from the 1913. 2013, and now we connect from the national hospitals to the province hospital. We call the satellite system for the telemedicine. In the 2017, we have a regulation on the telemedicine. In the regulation, we regulate the law for responsibility for doctors for consultation on the telemedicine system. I think it's a very important regulation for the telemedicine in Vietnam. And as you know, Vietnam is a very good reaction with the COVID disease. And in this year, we issue a program on the telehealth on telehealth from this year to the 2025, and with the objective that we can connect from the national hospital and the province hospital to the district hospital and to the the health commune, and it's the first from the doctor to doctor. Is the second, and we develop the strategy for connect from the doctor to the people, and with the objective that each citizen in Vietnam have a doctor, and we decide to develop we decide to push the company, the health company in Vietnam to develop the telemedicine platform and integrated with the hospital for develop the telemedicine platform in each hospital in Vietnam, and the second we developed the mobile app for connect from the doctor to the people, and we connect the telemedicine system with the national electric health record, and you can connect to the medical equipment such as the blood pressure equipment, the temperature equipment, and so on. And we want to develop the network of the telemedicine system in Vietnam. I think the different of the Vietnam, for the with India, that we want to connect the medical equipment into the telemedicine network, so that each person can self test the vital sign and send directly to the doctor, or send to the electronic health record and share the record to the doctor. It's on the strategy for telemedicine in Vietnam, and we push on the company, on the health e-health company in Vietnam, and cooperate together to develop platform for the each hospital in Vietnam. That's on our strategy. And I wonder if India can develop more medical equipment and connect with the telemedicine system for the people can shell test the vital sign and send automatically to the doctor via the telemedicine system.
That is very much possible. Some of the solutions which I mentioned about the evaluation telemedicine registry and the evaluation exercise, which I mentioned about it. So there are many solutions which are already available, which can do that. They can pick up the readings from the connected medical devices. So it is possible, but not everyone. And not everyone would like to kind of have that. Some kind of affordability is also there, but there are situations where there are people who are already using it. In fact, very interesting that there are some hospitals who are already also offering this kind of a package, which is sort of like stay-at-home kind of a care package during COVID. So they will be given pulse oximeters and a couple of other devices, which can actually which they can monitor and then relay the reading. So that's already happening.
Yeah, yes. Thank you. And the important that in Vietnam now we develop parallel 4 systems in the health, and we connect it together. The first is the electronic medical record in each hospital. The second is the electronic health record, national health electronic national electronic health record. Is the third is the patient registry portal, and the fourth is the telemedicine system. And we try to connect the 4 systems together, and the patient can go everywhere, and every time can connect to telemedicine system and share the information in the health record, put on the national health electronic health record.
Thank you, Sajai and Dr. Pham. Before we wrap up this session, we would like to share with you that period of application for certificate in reimbursement program is extended. For more details, please visit our website. Once again, thank you to our speakers and to our participants for joining this call. And we would like to call on Dr. Bunchai to close this session.
Yeah, thank you very much for everyone, and thank you, Jai and Reactor from our CLMV countries. I think this session is very fruitful, and we should continue. And I would like to emphasize that the certification program that Dr. Pham mentioned is still open. So please tell your peer to consider and to register for that. And thank you and good night. Bye.
Thank you, Dr. Bunchai. Thank you, Dr. Pham. Thank you, Cha. Thank you, Dr. Sambath.
Bye bye.
Thank you, everyone. Thank you very much.